We're live.
We are live, February 5th, Senate Education in the afternoon. So as we've been doing our work this session several times, we've heard allusion to the connection between the costs of education and healthcare, and had, I think, several times questions asked about like what are we actually doing, and I along those lines in healthcare in general, the low costs, and I'm very much aware of the work that the Senate Health Worker Committee has been doing over the last at least a couple of years in particular. And so, and Senator Weeks actually, made the point a few times to hear something from somebody, and so I immediately went to Senator Wyatts as somebody to, I guess, just give us a sense of, I think so. One of the senses is that the healthcare is just continuing to rise unchecked, and until we deal with that, it's very hard to deal with anything having to do with the cost of increase in education spending. And so we take a little time to get a sense of what's actually going on the ground, or in the other committee room, and then beyond, because I know it goes beyond, but I also know you're well aware of everything. So, and I really appreciate, I mean, all the moving pieces of Vermont and some of the things that have been done by, for instance, with the healthcare board. Well, so thank you very much for volunteering to come in. When I asked you, you immediately said, I'll do it. Probably regretted it later, but you said you'd do it. So here we are.
Well, thank you.
And we all know each other, so we
so everybody around the table, some more than others. So it's great to know you all. For the record, Senator Jenny Lyons. So volunteer is an interesting word. So, but so asked to come in, and I'm happy to do it. And I did spend a little time going through some of the work that we've done. I have a handout for you just on the bills that we worked on last year. So we'll keep a clean copy. And it's a compilation of, it's a short summary of the bills that we've passed out of our committee and that we did report on the floor. So a lot of the reporting you've heard. And then I went through and did a quick analysis, working with others to try to understand where the savings are coming from each of these bills and what the results are that we're seeing. There were predictions about what would happen, for example, with what we call reference-based pricing. But then there have also been some results that are coming out based on the work that the Green Mountain Care Board and the Department of Financial Regulation are doing. And I do understand that for Senator Weeks and Senator Williams, who were on health and welfare, and some of the language is familiar. For others of you, it may not be less familiar. I didn't do as thorough a presentation. I don't have PowerPoint, but I do have some slides that I've used in the past, and ultimately happy to share information with you. So the question is, and it's a question I think we've all been asking, and it was part of the work that we did last year with S-126, now Act 68, is understood that healthcare has a significant effect on education costs. And so then the question comes out every time people start talking, it's about, if we solve healthcare, we'll resolve the whole property tax problem. That's not exactly true. And there's two reasons it's not true. One is we're not solving healthcare that quickly. On the other hand, it's not true because the property tax situation is related to other things than simply healthcare. So we all know that. All right. So you have these bills listed. And I thought what I would do, and you can ask me questions, stop me, and we'll try to make it as clear as possible. I thought I'd talk about each of the bills briefly, and I'll try to identify the savings that have resulted from the work that we did. So there's direct one-to-one correlation, but correlation's better. cause and effect, but I think there's cause and effect in here. Anyway, we'll look at it and see what the savings are. And this is from looking at the Vermont program that we have called VHI. So Act 126, you're all familiar, did a lot. One of the things it did was to establish the development of a statewide plan to have regionalization for healthcare services. Another thing that it did was to put in place work on having electronic medical records that would be accessible for patients and providers. Another thing that it did was to have the Agency of Human Services work with hospitals to reduce hospital expenditures this year by at least 2.5%. That is happening, but that would be for 2026 this year. We are seeing the results of our work on what's known as reference-based pricing for hospitals. So paying hospitals a set amount for a set service. And I'll tell you what reference-based pricing is in just a minute. But that is also part of that bill. So that was a pretty big bill. It is also a bill that is now reverberating in other states. The other bill that we looked at that we passed was Act 49, which gives which is more about reducing prices in hospitals when there's an emergency, and that was to help preserve Blue Cross and Blue Shield solvency. That has had effect, and Blue Cross and Blue Shield is resolving some of its issues. Act 55 was a bill that we passed to put a cap on high cost infusion drugs in hospitals and other drugs in hospitals, put a cap of 120% on the average sales price. And so that bill is also having an effect. All of the bills together, and there was another one, the other piece of Act 126 was something that resulted in a Department of Financial Regulation order to open up contracts between health insurers and the providers. So I am happy to start wherever. I will start, I think, opening up the orders, which is DFR order. Department of Financial Regulation regulates insurers, so health insurers. When health insurers work with providers and negotiate with providers, they establish contracts for timely payment, amount of payment, and so on. Prior to this, the bill that we passed, those contracts were black boxes. So, which means that no one can see inside what's going on. And so you could end up with a price here and a price there. You could end up with a NDA, non-disclosure agreement, and other things that were detrimental to transparency. So 126 sort of opened up those black boxes a little bit, and the DFR the Department of Financial Regulations has responded and putting conditions on those contracts. That's a good thing. And the insurance companies are happy with it too, because it takes them out of this conflict in negotiating. So let's leave that one aside for a minute. Yeah.
Can I ask you a question? How many insurance companies do we actually have that are affected by it?
We have, affected by it? I really can't answer that. I don't know how many, but I know the biggest one was Blue Cross and Blue Shield. And then there's MVP, which is the other health insurance.
Okay.
But so Blue Cross and Blue Shield certainly represents, most of what are known as our quality health plans for folks.
Mm-hmm.
Yeah. And then also administer some of the plans for our businesses, our small businesses. Yeah. Hospitals. So I think you're you want to hear the dollar figures, and I get that. reference-based pricing is something that was. Reference-based pricing is a benchmark price. So it's a benchmark to Medicare, how much Medicare pays for a specific service. So you could have, suppose you have a Medicare reference-based price of 200%, so it'd be 200% of Medicare. So when what we were seeing and what we know is that the high cost of care is very much directly related to the high cost in hospitals. And we know the result of that is extremely high cost for the resulting premiums. So if you can control and regulate hospital payment to hospitals, then you can begin to lower premium costs. Reference-based pricing is an opportunity to put the sort of this capitation to slow down the increase. Reference-based pricing in some hospitals, the Green Mountain Care Board was seeing as much as 580% of Medicare. And then and so if you say, oh, wow, that's great, so we'll lower it to 200%. That doesn't take into consideration utilization. So if you've got a service that you're doing over and over and over and over again, and it's at 300 or 400% of Medicare reference-based price, you're getting a lot of money. So part of what will happen next, and I'll give you the next steps, part of what will happen next is for the board to balance how those reference-based prices are used, depending on services, depending on the utilization of services. So it becomes a fairer determination of what a real cost might be for a service. So that's reference-based pricing. And the point I'm making about utilization is that, and also I'll say utilization is one. Then there's another thing called, if I get too wonky, let me know, okay? It'll all sugar off soon. I'll have money out there for you in a minute. There's something called balanced billing, where, if you charge a lot for this service over here, but it's rarely used and you're not making enough money, you could charge a lot for another higher utilized service. So kind of balance out how much money is coming in. That doesn't actually reflect the patient needs or the service needs that are within the system and within the hospital itself. And I will say, and I'll just say this right up front, this all sounds like, oh, those bad hospitals. The reality is hospitals have been extremely responsive and understand this. So the way to lower costs, one, is how you pay for services. The other way is administrative costs. And hospitals have been extremely responsive to those issues because they understand their financial sustainability is as much related to this work as our patients' access to the care. And on Friday, if you're interested, we're having some hospitals come in and talk about the work that they've been doing since 126 was passed. They've been very responsive and very good. So I wanted to put that up. Should have put that way earlier. So reference-based pricing is one thing that we can do to sort of look at costs, hospital costs in particular, and then that will sugar off down to the premiums that folks pay. The other thing that I mentioned earlier is the cost of drugs, and so what patients pay for drugs. Without going into all the reasons why we did this, we predicted last year that we would see a $12 million savings for drugs and a 3% decrease in premiums. What we're seeing and I'm just talking here about education. I'm talking about lives covered by education, the 32 or 33,000 educators and families and staff. what we have seen is, a savings on the infusion drugs of in $14.6 million. That's its projection. For 27, the prediction is $16 million savings. It's happening. It started January 1st. And then there are some other savings that will result from a change in which drugs are covered. So the educators predict at least $16 million savings. The other thing that we're seeing is with the Green Mountain Care Board is regulating rates, and it's all due to all the conversation that we've been having and the legislation that we've passed. And the board has begun to look at hospital rates, insurance paid rates differently. So there will be a savings of about $88 million for budgets, hospital budgets. If you raise hospitals at 3%, the $88 million that will go for those savings. Just hospitals, okay? If you look at VHI, if you look at educators only, the cost for education, healthcare, 55% of it is hospitals. So the total savings, there is math in here, believe me. The total savings for that will be about $9.6 million for educators and their coverage. Okay, so if you have that $9.6 million and you have another $16 million, and then with the oversight, reference-based pricing and oversight, the total savings that will be accrued is about $40 to $48 million, $40 to $50 million. That's what we're talking about with the legislation that we passed. And that's really a fairly, I don't think it's a high number at all. And it's only for this cohort of patients. So we're not talking about everybody else here. We're talking about a small group of 32,000 people. That's what we're talking about. What that results in, and I know you have a question.
Just want to be sure he's clarifying.
Judge, Madam Senator, for a while.
You go,
I'll stop.
No, you go.
Keep going?
Mhm.
Oh, okay. So there will be more than a 3% decrease in premiums. That's all. I think it's 7% decrease in premiums. Find that. I better be.
So are them savings per year, that 48?
Yeah.
Okay.
And let me find one. Yeah. 14.6 to 16 million. Yeah. And that will, average premium. The average premium increase would have been 10 to 15% on its normal conditions. Under the conditions that we have as a result of our legislation, the premium increase will be 7.34%. That increase will also include money for reserves for VHI, for the business that manages healthcare. And because they were losing money too. They're a payer. They're losing money just like Blue Cross and Shield. Blue Shield is losing money. So this will allow for them to become whole or more whole. So there's a lot of, there's money in here that you should, I think, if you're interested in more specific data, VHI is a really good source. They are an exceptional organization. Green Mountain Care Board can help. Remember, this is only about hospitals and drugs, a few drugs. It's not about the whole world of healthcare. And we're still working on that.
So my clarifying questions, the numbers you were giving us with those, did that relate to the cost for VHI, or did that relate to the cost overall for everybody?
VHI.
That was just.
Only,
So
I'm
you-
only talking education
Okay,
here.
okay.
You wanted, this is
No, no,
education.
I just want to make sure I understood which number. So the other, on the systemically, was big, a lot bigger than what you're.
Well, see, one of the decisions that we made last year when we put the committee bill together, I felt very strongly, I very much appreciated VHI coming in and saying, let's do a pilot program for VHI. But if you do one cohort and you save money over here, that means the bubble expands somewhere else. So it's for all hospital payment. So if you segregate out, then you can start to figure out, well, what does it do for this group? What does it do for that group? So this is what it does for educators. Period.
Okay, I think you.
It should help other people. The elephant in the room, of course, is the federal government problems all there. We have to deal with that.
Senator Williams, your question.
So I think, I'll show my ignorance a little bit here. I shouldn't, because I was on your committee for
That
2
does,
years.
you know what? It takes 100 years.
So I think the general perception from a 30,000 foot view out there is that, because there are so few insurance companies, providers, that they have a monopoly on everything. Whether it's true or not, I know you're gonna tell me. But- And the other thing is, if we could take all the groups, just the state government, the state employees, all the classes of employees, including and the teachers who are not state employees, and put them all under one umbrella and get companies to compete for providing insurance for that, and we can bring the price down. Is that accurate or?
So you've asked two different questions.
Okay,
So, competition has actually gotten us where we are today.
Right.
And then we've got all these little small groups out there, right? All this, the self-insured, all over the place, which represents over 200,000 lives in the state of Vermont. That's a whole lot of small little group. But your observation that making a bigger risk pool will help. It does two things. It spreads risk, change the clinical profile for people so you can have different types of coverage. And it will lower costs. It definitely will lower costs. Well, so if you say, well, let's have competition for all these different payers to come in. Well, then what will that do? That'll split the risk pool up. So, that hasn't worked. So bringing the risk pool together, bringing more lives together, is the right direction. And that's exactly why having it be a hospital-based, not an individual group-based type reform that we looked at last year was so important. And then similarly, so we're next looking at primary care and how we do a similar thing here. The bigger the pool you have, the more you spread the risk, right? Or you can pay for it.
and we have an aging population, so
Oh, yeah, don't
Certain-
forget that.
hospital services, are concentrated in a certain area.
Right.
So I think that there's a lot of misperception out there that.
Yeah, there is. Yeah,
And
yeah.
we probably need to clarify. I see what you've done, what we've done is progress.
Oh, it's huge.
To reduce the cost that much.
Yeah.
That's savings.
It's huge. It really is. I'm really happy that we did it. And I know there are people who have doubts about it. But other states are looking at what we've done and wanting to emulate. So and the savings are real savings. You don't feel it in your pocketbook right now because this is something you don't turn a ship this size overnight. I won't use the word begins with T, but better boats that you can turn that stay afloat.
Well, so how can we take the insured population that we have, just the state employees, and get them together? Why can't we do that?
Well, I'm working on it.
Okay,
Yeah. Well, why can't we do that? Because it's always more, our little bumper sticker that we have that says it's more complicated than that? It is, but it's all about people. It's all about, willingness to make change and do things that, are outside of your own place.
We have one of our major insurers that filed, was ready to file bankruptcy. And why was that? Can you tell me?
The solvency
Yes.
question?
Yes.
Yes, it was all because of the black box contracts. I would say all because, but part of it was they got the little black boxes. They're negotiating with a huge hospital that requires a high payment. And then they can't make it up somewhere else. So the money goes to overutilization, keeps going out, and then you're left with a lack of reserve money. Yeah. And who do you blame for that? Nobody, because that was competitive, the larger hospital is competing for survival. Other hospitals are in the red. How can they compete, at the same time? So if there's nothing, if there's no regulation, we're going to see a lot of our smaller hospitals die. And so having this level of regulation for the small state that we are makes a lot of sense.
So, Senator Lyons, I have complete respect for you. I believe you're the current dean of the Senate, the longest serving senator.
No,
Oh, yeah, well, you're up there.
so
You've got long service, with service. comes
Vice dean.
experience. Vice dean. And you've been the chair of the Senate Health and Welfare Committee for quite some time. In my world, where I came from, my last project was worth about $3 billion. We were judged on results. We weren't judged on, it didn't matter what we said. If our numbers weren't coming out, it was personal. The fact is that Vermont's healthcare costs are roughly 3 times those of New Hampshire, 100 miles to the east. And I have a constituent who paraphrased what he believes is the current challenge with Vermont. And that is that we have a 40-60 rule, meaning that we have 40% of the population who pay for themselves for their healthcare, and this healthcare is specific to Vermont. 40% of Vermonters pay for their own healthcare, and they pay for the other 60%. As a 40,000 foot view of Vermont's healthcare challenge. Now, my question is, do you think that the real problem with Vermont's healthcare spending is hospital spending, or is it in the level of entitlements that we keep adding to each year?
you're worried about supporting people who are on low income?
The 60% of, for whatever
Well,
reason,
actually, the largest group that we have in the state of 67% of the people who are insured in the state are self-insured, which is private insurance, not a separate private insurance. So you want to get into the numbers. The lowest number of people covered are their quality health plans, with very few who are actually paying in the quality health plans. And then you've got the self-insured, which are our business insured, including education. So that argument doesn't go very far. Do we have a lot of people who are very low income? We don't have a high economic standard across the state. And so if you treat healthcare as a commodity and you must purchase it in order to be healthy, then you would say, well, then we shouldn't have a safety net. But the reality is that we don't always have control over our healthcare and our costs. So this is the debate, it's a fundamental debate about whether healthcare is a public good or whether it's not.
Okay.
So, I can't answer all your questions right now. If you want to have more detailed numbers from Nolan Langwell, we can get those for you. We have those, Healthcare 101. I didn't bring that data with me. I brought the data on the savings that we're seeing as a result of the work that we're doing.
So let me rephrase the question. So do you think we're attacking the right problems?
I think we're attacking the right problems. Well, you know, until the federal government stepped into the middle of it. Even with the Rural Health Transformation Grant, I think we're solving the right problems. Because we're lowering the cost of care that has risen exponentially. You identified it perfectly. New Hampshire pays a lot less than we do. Our academic medical center was the highest cost academic medical center in the country. This is their state health insurance benchmark plan cost. I brought this to show you. Vermont is way up here. Maine is here. New Hampshire is here. The US average is here. Well, what do you do here? What's in here? Okay, administrative costs, increased efficiencies, reference-based pricing, lower drug costs, all of those things are in here that are different. And now other states are looking to see what we're doing for each of those. And there's others. Primary care. An investment in primary care of $1 yields a $13 savings. And how does that happen? It happens both in the pocketbook going forward, you know, for people who now are getting the care they need and they don't get the cardiovascular disease later on. So some of these things take time. So we're gonna have to wait. But some of these things are paying off right now. That's the money we're saving. And we also should remember we want to see public health outcomes. But we're not going to see that tomorrow. Like to see it.
So we have to move.
I know.
But a couple more.
Was there a good analysis of why Vermont is so much higher than our two sister states? Is it because of our 55 and older demographic and there's only 650,000 of us in the state, or what? It's just our hospitals are charging more.
It's complicated. And so I can't answer your question without going into every single level. Why are we different from New Hampshire? Is it the way they pay for their health care? Is it their population base? So they have a larger risk pool that they can work with so they have more money? Is because they have more taxes? I don't know. Economically, is it economics? Is it because their hospitals are not charging as much as our hospitals? And that really is part of it. So
I spoke with somebody that was in insurance and they said they believe that one of Vermont's problems is that most insurance companies look for 2 million bodies or
risk pool.
Risk.
Yeah,
yes.
Exactly. Yeah.
And it's like, well, gosh, we can't even come to half of that in Vermont. So should we open it up to bigger insurance companies that they can take the risk pool, can go outside of our state as well as just Vermont?
Wouldn't that be great? So, and I'll let you know that one of the sections of the primary care bill that I have in committee now is to have an exploration of exactly that, to have regionalization. So we talked about regionalization in the state for our rural health transformation, you know, this part of the state, this part of the state, which is great. But then what benefit would we get? Exactly what you're saying, from being able to expand and have some kind of financial and healthcare oversight.
Because I believe it's still for us older folks, still getting cost what it costs, but younger families might be able to get a premium that is a lot less.
This is what you want. No question about it. Having these large, as you say, we want to have a large insurance company come in and merge populations. Blue Cross and Blue Shield is a large company, so is MVP. But that's not the way our insurance system works. It works on the borders.
So I have a note in front of me.
Huh?
I have a note here that says they need you in appropriations.
Oh, nuts. Gotta go back to work.
We'd love to have you back. Maybe we could find a.
Well, you're asking questions that I think there's some data that you probably want, but well, and I did think about the numbers and the number of people who are covered, but I thought you just wanted to hear what the savings were as a result of the work that we did. So that's.
We would ask you questions all day if we had the.
Well, I know, I can't answer them.
So,
so
okay.
I-
Senator Runs.
Well, I just wanted to say something maybe to watch that would be helpful, that superintendent's raised is people taking more advantage of family plans now that the subsidies, the ACA subsidies are gone.
Subsidies are gone.
And middle, family plans are kind of a $40,000 employee cost education fund for many. So watching that trend, if it changes dramatically.
So that's true. And looking at the cost and trying to sort out how to fix those plans, it's really important. We're not going to do it unless we have systemic changes. And we're not going to have systemic changes until we start doing some of the things that we're doing that look like there's not a direct link, but you're right. All right. Thank you.
Thank you. Thank you.
Thank you.
Yeah, that was helpful. So thank you very much.
Money.
Yeah.
I'm leaving. Hey, you don't want to hang?
Yeah.
Are you all ready for me? Okay.
Just so I know that you have a fact.
I mean, I could come up with one.
Okay. I just want to know if you had to do some work.
No, 3:30 is my next
So
appointment.
we get some. So we gotta have, I think we gotta have some of that side. So we have, that's good. You're ready.
Sure, Beth St. James, Office of Legislative Counsel. I think I'm here today to talk about the different operation models in the current technical education universe. I made the most basic of handouts for you all, but I think what we'll do is probably spend some time just looking at the actual law. So CTE, and I think you can use the term governance models. I don't love that because the bulk of everything is within the public school system. So, and even there are two different kinds of operation models that are operated by a local school board. So I think I like to think of it as operation models and not necessarily governance models, but I'm not the expert on CTE. This is just how my brain is working. So the most common operation model is a center operated by a local school board. A school district that operates some subset of grades K through 12 and operates a career and technical education center. That's the majority of our centers. The school board operates that CTE center in the same way that it operates the rest of the schools in its district. However, it is required to establish a regional advisory board, and we can look at that statute to see what their role is. It is a consultation role, but there is language in there about if the school board does not take the advice of the regional advisory board, there is actually a process for how to rectify that. And the school board is setting CTE tuition subject to the State Board of Education rules. So this is the vast majority of our career and technical centers. Then we have comprehensive high schools. Bless you. Comprehensive high schools is defined as a high school, a public or independent school other than a career technical center that provides secondary career technical education approved under section 1533 of this title. There are two different types of comprehensive high schools. One are the comprehensive high schools operated by St. John's Bury Academy and Linden Institute, so two approved independent schools. And then there are two public high schools that have been deemed comprehensive high schools, Canaan and Missisquoi. Canaan and Missisquoi are operated just like those CTE centers by a local school board. They are not CTE centers. They are comprehensive high school, and they do not make a separate assessment charge. There's no separate CTE tuition. If you are a student tuitioning to either the independent schools or the public comprehensive high schools, you're paying the full tuition charged by the school to attend the school. Whereas the CTE centers, you're paying tuition to attend the CTE center, and you're still receiving some amount of education elsewhere.
So, so how does that work when it's come from part of the day to one of the comprehensives?
To one of the comprehensives, I don't know. I don't know how the proration of tuition works.
But fundamentally, they don't separate out the CTE from portion of what they do from everything else. It's all this one.
There's no, so CTE tuition is set by state board rule. And there's a calculation that our publicly run CTE centers have to follow to set their CTE tuition. And then there's a whole bunch of salary and assistance and tuition assistance. That calculation is not applicable to comprehensive high school. So they're setting tuition under the tuition statute. How that proration works, I don't know.
But there's kind of another question in there, I guess, which is any of these could be half-day models.
I guess theoretically, yes. Yep.
Because it's not like set in statute, but I think that ends up being a really big question mark for that area, is there's only a half day, and how does that work with the school calendar of their partner district or districts?
And then the last operation model, usually we hear folks talking about 4 operation models or governance structures, and they're talking about the independent schools, the comprehensive high schools, the regional tech center school districts, and then the locally operated school districts. I've lumped comprehensive high schools into one because they are one. There's just 2 different types within them. So I have 3 operation models here. And the last one is a regional career technical center school district, which is a standalone school district. It is a career and technical education school district that is formed by the vote of its member school districts, which are its sending schools. It does not have taxing capacity, so it's not raising its own taxes. But for all intents and purposes, it functions just the way a school district would. It's just the only school it's operating is the CTE center. And I believe there are 4 of those in existence right now. So the most recent example is just down the street, I believe, in Barrie. I don't remember the Central Vermont Career and Technical Center, I believe is what it's called. Just a couple years ago, they moved from this first model, a career and technical center operated by a local school district, I think it was Spalding, right? To this regional career technical center school district, where all of their sending school districts got together and had a vote and decided to form this standalone CTE school district. There's no regional advisory body for the regional career technical center school districts. They're just focused on the CTE center.
Yes.
The quick question, sorry if I already covered this, but so for these 4 regional centers, the districts that govern that region, where the CTE is, they all leverage they all have the taxing capacity to pay for that CTE?
Yes.
And is it based on how many students each district is serving?
Yeah, let's pull it up and look at it. So here is the subchapter, so I'm in chapter 37 of Title 16. This is where everything related to CTE lives, with the exception of tuition for the comprehensive high schools, which lives in our cap tuition program statutes. Everything else lives here. So you've got, these are our local career and technical education programs, and what's the responsibility of the local school board, what's the responsibility of the sending districts, et cetera. Eligibility and tuition, state financial assistance. And so here is the Regional Career and Technical Center School Districts. Here is their budget language. So the board of directors presents a budget every year. And they, let's see. The board adopts the budget. It's not going to a vote of the voters. And then subsection E is the nitty gritty. So following adoption of a budget, the board shall calculate each member district's share pursuant to section 1552, which is the CTE tuition statute. Upon receipt of the notice of the amount, the share becomes the legal obligation of the member district without need for further vote of the member district electorate, and shall be included in the member district's education spending amount.
And the board of directors. Well, actually, never mind. Thank you.
So what is the basis for, when they say calculating each number of districts? Because I always thought it was for student count.
So secondary student tuition is established by each center, and it reflects the actual cost as defined by rule of the board of attendance in the courses offered by the center. And so then it says tuition shall be reduced proportionally for students enrolled in a part-time program, but how that actually works, I'm not the math gal. So we would have to pull up the state board rules to look at how they're setting those tuition calculations.
Well, I mean, I don't want to share my screen if it's premature, but I was gonna ask Beth if there was a map of these, and I think John Adams would be proud of me. Both John.
Oh.
But I've overlaid the CTEs with the state commute patterns and the districts. So we have the data, I would say, on where gaps might exist or why we have shortages in some areas and overabundance of slots.
Desert.
Yeah, all of the above. Deserts, oases, etc.
We have the tools.
I know, thank you, GIS people. It was easy to figure out.
Yeah, so that's something to look at, obviously. So it's one of the
If I could,
things we're thinking about. Why don't we just spend one? I'm thinking about, we want to move other questions for Beth about the models first.
yeah, I'll just email this to Daphne and she could tell me if it captures the map layers I put together. Then people can take it from there.
There's a lot more to CTE than just their operation models, but that was what I understood you wanted to learn about today. And as with everything, it's all made up. So you get to decide if you like these, you want to change them, you want to make a hybrid, it's all in your hand. It's all in your hand.
So one of the, with the comprehensive, so this is the, it's can just treat a class like it's a class. They can go from their English class to an ornament photo class, then back to history.
I don't think that the Title 16 speaks to any of that. I don't think Title 16 is that specific.
Okay.
It is a high school that offers CTE programming that is not a CTE center. That's the specific example you can get.
I'm only thinking about how visiting kids fit into that model for kids from,
Mhm.
and it's because it's a somewhat different. Operationally, at least I know a couple things operate differently, but like we've got Bennington's is number 3. Number 1 and 4. And that tends to be half day, full day.
I don't know. I think that would be a good question to ask those schools how that works.
Yeah. Any other questions?
So just a comment, we took a lot of testimony. For the last 2 years or 3 years from St. John's River Academy.
Yeah.
Basically, when they were enrolled in the CT portion of that, they actually went to math class and learned about math. They were units.
Oh, I was just, I screenshotted it, but it's, because it did not, the link did not. And it's very interesting.
Okay, well, we just wanted to get that refresher started point for our thesis discussion. Other questions that we're done.
Okay.
Um,
I mean, maybe if we want to dig into some of this.
we have a few more minutes.
Yeah, I don't want to keep people from other errands, but I think and I want to do this with Beth here because I feel like statute could either be silent on some of these things and then the rest is left for us to fill in the blanks. I think a lot of our questions going forward would center around how to make sure there are not disincentives for sending a student to a CTE, wait lists, denials, or trying to keep them in an academic center because the district doesn't want to lose the money, or the high school doesn't want to lose the money to the CTE. Do you have a sense of past efforts to try and address that through these models?
Not necessarily through the models themselves, but you guys last year in the miscellaneous education bill tried to address some of that. Let me see if I can pull it up. And I feel like I'm a broken record lately, but
Probably important when you stop again.
it's really hard to control human behavior.
Yeah.
So you can get the language right, and you could get agreement from all the stakeholders that this is what's going to do it, and still get feedback from the field that it's not happening.
Mm-hmm.
And I think anecdotally, that is what as I sit in your committees and I watch the testimony you're taking, sometimes I think that is part of what you are hearing is that the law is there, but there's something else going on. Mm-hmm. And so there's no amount of legislation that's going to necessarily fix the problem. That doesn't mean that there aren't ways to legislate around some of the barriers to access. Let me just pull up last year's miscellaneous bill and you can see what all tried to do, all of which I think is already allowed under current law and is a good example of trying to really be clear at what is allowed and okay under the law, even when the law kind of already allowed for that.
Mm-hmm.
I think this was a very late addition at the very end of the session. I think it was Senator Hardy who came forward with it.
Oh, they have it for.
Yeah, so so this was just passed last year, so I have no idea how it's working. So section 18 of Act, I think it was 72, yep, 72 of last year. We've got some definitions there, but then we've got a whole series of subsections that are trying to address kind of discrete issues. So one is allowing secondary students to apply for enrollment in programs offered at CTE centers outside their service region when their assigned service region does not offer the program, or they're not enabled to enroll in a program of their choice. The school district students residents shall pay tuition for that enrollment pursuant to an agreement between the sending district and the receiving district. I think you heard testimony that there were wait lists and kiddos were not being allowed in or not being accepted into programs outside their service region.
Or, well, more so may not be told about opportunities outside their service region and not like a concerted effort to make sure they could get there, right? It was you're on your own language about transportation that particularly Nicole McTavish was trying to solve by saying we would pick students up.
Yep, and so we've got some language here that says a regional CTE center may provide transportation to and from. I think there was confusion over whether they could even do that.
Right.
And so this is saying you absolutely can. You can go pick them up.
Mhm.
Hanford does.
I mean, I sent Daphne the screenshot of the commuter map and you can see why they need to. This is not on the way here or there. For many students, they need help getting there.
And then there's some tuition reconciliation language in here that's already outlined in state board rule. And then there was language that requires a school district that maintains a high school to provide requested directory information of enrolled students to a CTE center located outside the school's district for the limited purpose of the CTE center providing information to students and parents about their offerings.
Mhm.
Again, I think this is already allowed under current law, but we're spelling it out here.
Right. And this was kind of the opening question in our working group for people like Ruth Durkee. You know, what tools would AOE need to enforce this? Not just say you may do all of this, but like we should not be hearing about wait lists and denials if there's a way to help those students get a slot somewhere.
Senator Rushing, that question.
Yeah, this isn't a loaded question, but I'm trying to figure out, are we taking a deeper dive on this as it relates to Act 73 or Senator Bill's bill
Kind of
for?
connected.
Yeah.
Yeah.
Okay, I'm just trying to get an idea of why, like what specific changes we're contemplating or just trying to learn more in general. Okay.
Learning more general to get set up.
Got it.
No,
So, yeah, yeah.
So I don't have any answers. But whatever legislation we do craft, again, it depends on what your goals are. But it doesn't necessarily matter if we think the language works. If the folks who are in charge of executing it think that it's not going to work to do exactly what you think it does,
Mhm.
that is important feedback for you all.
Right. Right. So I think we heard Eric Remmers and VACTA come in and talk about some teeth to this. You know, there has to be a way to say this has to happen or else, and hear from the schools about how punitive the or else would be. I mean, why aren't they trying to help facilitate those students' access to other places?
And they may think they are.
Right.
Yeah, so anyway, Senator Williams.
So I understand, I may be wrong, but the current system, that sending schools are now required to provide transportation to CTE. So, and I know that CTE centers charge significantly more per student
Mhm.
than what the LEA actually gets. So maybe twice as much.
Mm.
And then is there a reason for that? Why their cost to run the CTE centers more expensive?
If you're looking for a policy answer, I can't answer that. There is formula in state board rules for both for net cost per pupil, which is what public school tuition, how that is calculated, and for CTE tuition. And so we would have to pull apart those rules and see what's contemplated in there. But both tuitions are supposed to reflect the actual costs of educating those students.
Ruth would probably come in and be able to talk about the specific rolling average. I think it's over 3 years or 6 semesters or 6 semesters. That can be really challenging for Hannaford, for example, because they have such a high cost per pupil because they don't have enough students. If they added 50 students, that cost per pupil could go down in 6 months, but it wouldn't register in the formula for 3 years.
Digging back into my, foundation formula, is that gonna equalize out under the foundation formula? Are they gonna be paying the same for CTE?
Act 73 didn't make any amendments to chapter 37, which is the CTE chapter where the tuition sections live. And I'll just leave that there.
I don't want to be wrong. Like, I'd like to see if this is your understanding that the study, the consulting study group is supposed to come back with some thinking on a CTE foundation formula alongside the other formula.
Yes.
And if I could be misremembering this, but somebody like Tammy Colby did come in and say there are models where they might say, here's the formula for aeronautics, here's the formula for performing arts. You know, I remember some reference to like they do have a way to compare like costs for like programs that involve equipment or don't involve equipment or insurance costs.
Thank you. I'll look at it with you because it's about something else. We have, the UVM can't get here until 3, so we have a
Didn't they say 310 maybe to you?
real line, maybe.
Real
We'll
line.
call it 3. We can try and do that.
Okay.
Like, somewhere on, we can go up till 3.